Good morning, everyone. Welcome to Pediatric Grand Rounds. As always, thank you for joining us online. And if you are anywhere near the Tanglewood Complex, please join us in the Mill Mountain Conference Room. Today's speaker is Dr. Richard Cordle from the Department of Pediatric Gastroenterology, Associate Professor of Pediatrics at Virginia Tech Carilion School of Medicine. He grew up in Richmond and attended UVA for medical school, WashU in St. Louis for medical school and fellowship, and completed a 3-year residency at Wilford Hall Medical Center in the United States Air Force in San Antonio, Texas. After fellowship, he returned to the Air Force in San Antonio. He served on staff there as a pediatric gastroenterologist with San Antonio Military Pediatric Center. He joined Carilion in 2002 when pediatrics was based at Community Hospital, and before there was a med school or Starbucks in Rhode. How do you survive? When not spending time finishing charts, his words. He's focused on his family, which is everywhere, Nashville, Miami, Wilmington, Delaware. Please join me in welcoming Dr. Richard Cordle.
So I tried to, good morning, thank you for coming in. I tried to approach this. I wanted to look at two entities that are very similar, but then they almost morphed into two lectures. So I'm going to try to cone that down. So CVS and CHS. So first we're going to learn how to recognize these disorders. We're going to learn how to make the diagnosis and then learn how to do therapy for them, both in the acute setting but also for long term. So they're very similar. We're going to approach the kind of a similar approach to both topics. So what is, first off, we're going to learn about vomiting for a couple of slides. We're going to talk about something called the Rome criteria, which is the criteria used to differentiate disorders that are functional. We're going to get a look at the clinical picture of cyclic vomiting syndrome, how to manage it, then how to manage these patients long-term and prevent new episodes. And then we're going to talk about cannabinoid hyperemesis syndrome, which is CHS, and similarly acute and long-term management, and then try to talk about differentiating them. So just a quick flyby about vomiting. So just what you wanted to hear about this time. So the vomiting center is located in the medulla at the brainstem. And so inputs come to that area and then it triggers an event. So if you look at this shows how these stimuli come to the chemoreceptor trigger zone, and then that starts a central pattern generator, which starts a program of vomiting. So just as you think about it, inputs from the brain, so you smell something, your child just vomits on your lap, and then you start to get nauseated. You start to get obstructed in your GI tract that sends serotonin 5-HT3 to the CTZ, and then you start to want to vomit. And so that's, once you have turned on the vomiting program, it is started. It's like the horse is out of the gate, and it's you're going to vomit. And so when you start to vomit, you have changes in the back of your throat. You close your glottis. You stop breathing. You increase your abdominal pressure, and then wham, the stuff comes up. If you're doing an endoscopy and you see someone vomit, the whole stomach just comes right back at you. This isn't something that you walk over to a trash can and deposit what comes up. That's a different type of history. So this is a vomit, and it starts off with a impulse going to the CTZ, which starts a program. And that's what we're dealing with CVS and CHS. This is an important slide for us to think about for the rest of this talk as we start talking about drugs and interventions. So this is what happens at the CTZ, and these are different types of impulses that can trigger a vomit. So this is dopamine, this is serotonin, and this is substance P, histamine, acetylcholine. And so this slide is representing different blocking agents. So For dopamine, that would be prochlorperazine, which is compazine. This is on dansitron here, for it's a serotonin blocker. Here is histamine, that's what promethazine does. Here is substance P. This is something called aprepitant, which is an NK1 medicine. And so you're going to hear those names again, and I probably will bring this I'm going to bring this picture back up to you. So I wanted to give you that background that vomiting is something that's violent and triggers by the brainstem to get us started. Okay, so first, how do we differentiate these? So just like the DSM-5, a group of people meet together and they come up with consensus about what a diagnosis is. So they have to do this for disorders of gut-brain interaction because there's no test that you can run. These are pattern recognition. It's a syndrome. These are things that you look at. So people will gather in Rome. I kind of picture people drinking wine and talking about it, but these are conferences. These have been going on since 1988. And so both cyclic vomiting syndrome and cannabinoid hyperemesis syndrome are considered functional disorders. There's another one called chronic nausea and vomiting syndrome, which is like you're just describing what's happening. But these are the criteria, and this is dated back to 2016. So these are the most up to date that we have for the Rome 4 criteria, and we'll talk about whether or not these are appropriate for everybody. So just look at this. So you have stereotypical episodes of acute vomiting. Stereotypical means your pattern of vomiting is going to look the same every time you have it. It is individualized for each person. You're going to have many episodes in a year, but it won't be more than one in a week. 2 episodes in the last 6 months. So if they come to see you and it has been a while since they vomited, you might want to pause before you give the diagnosis. Remember, no test. This is pattern recognition. So symptoms over the last few months, and then in between these spells, no symptoms. So they go back to normal. So the only difference is this line here between these two. So CHS is associated with chronic use of cannabis or marijuana, and it stops with the cessation of it. So that's how we differentiate that, and it can be a challenge. So first we're going to talk about CVS, cyclic vomiting syndrome. So this was found and discovered or described in the 1880s by Samuel Gies, physician. Who can tell me what else he described? That's right. Starts with a C and ends in ELIAC. So celiac disease. So cyclic vomiting is characterized by vomiting, and it's recurrent, it's violent, it's stereotyped in its timing. So many times these people will always start vomiting at the same time. Typically it's in the early morning hours at night. The duration will be similar every time. It'll be 2 days, or it'll be a week, or it'll be 4 hours. The onset, like how it starts, will be similar. There'll be similar symptoms during it, how much pain they might have. And so then in between these periods of normalcy, so think about that. What kind of things in your mind are episodic? And when you get that, your alarm should go off. This is going back to normal. They're like a switch turns off. And then you can't really find anything else that resembles it. So how common is this? So almost 0% in children. This is actually somewhat significantly high if you think about the number of people we have. It tends to be a school age onset, the average age being 5 years of age, and more common in girls in general in this group, whereas CHS is more common in boys. And you can see this creates significant problems for their life. 20 days of school per year of absenteeism and lots of ER trips, lots of money spent on this. So what do we know about what causes this? What would make someone have this pattern of intermittent vomiting? And so some ideas some studies have come out and to look at this, but we still don't fully know. And so one thought is that this is a mitochondrial problem. And it seems like you'll see similar migraine type history in the mother. They might have, so that it seems like the genetics go through the maternal line, making one think mitochondrial. Also, they seem to resemble the kind of vomiting we see with fatty acid oxidation disorders or mitochondrial disorders. So if you have fatigue or fasting or an infection, if you can think about people with metabolic disease, they'll be triggered with those things. And so similarly, maybe this is a mitochondrial disorder. There are some polymorphisms that have been found in the mitochondrial DNA that are seen with people who have cyclic vomiting syndrome. So another thought is that it's an autonomic disorder. And unfortunately, many teenagers deal with what is seen to be paroxysmal orthostatic tachycardia syndrome, or POTS. And it's actually seen with some regularity with people with CVS. And that's like flushing, they may have pallor, they may sweat, and or they might have some endocrinopathies that develop from that. They might have increased ACTH or cortisol that's output. There's something called a SATO variant, which is seen with this. Again, we're trying to think about CVS, what's causing it? And these actually might be variants even. There might be CVS is a umbrella term, and these are variants. Another thought is that we've seen, there's a subset of people who will only have their cyclic vomiting event, just like with migraines around their cycle, their menstrual cycle. These men arise later, like during their teenage years, and every time, right as the cycle starts, they start to have symptoms. And then cannabis exposure may be a subset of CVS. Many adults with cyclic vomiting syndrome deal with their CVS by smoking a little weed. And so children will also hot water bathe, which is very emblematic of CHS. But the predominance of thought about CVS is that it's like a migraine. And why is that? Because they have recurrent episodes. There are intervening periods of normalcy, just like a migraine. There's usually a strong family history in up to 3/4 of patients. So getting that history doesn't mean they have CVS, but it's suggestive. Many of these children go on to leave their CVS behind and become full-blown migraine people. And this often happens by the time they're teenagers, and definitely by the time they're adults. A good percentage will actually grow out of them in about 3 to 5 years. You can tell parents this isn't going to be forever, perhaps. But similar to migraines, different types of foods like chocolate, cheese, MSG, either stress and excitement can turn on one of these, just like in migraines. Fatigue or exhaustion can also bother you. So I found this cute little picture. I thought this is kind of like a brain, someone's brain in their insides, showing how the CVS is kind of like a migraine. And I thought, and so then just this week, I thought, oh, maybe this is for real. Somebody can swallow their own brain. So, so what does it look like? How do if I'm looking in the clinic, and since this is a clinical diagnosis, how can I make the diagnosis? Well, it's very difficult to always be unified. They don't always behave in the same way. What about what if they got 50 minutes of vomiting? What if they vomit every day for 2 weeks? What if it's 3 days a week and then they break a couple of days and they vomit? So sometimes you can have some cognitive dissonance about making your diagnosis. But it's also true that when we start studying it, or going into the literature to figure out what's true about CVS, you have to think, these people are describing it based on their own sort of clinical diagnosis. There's no test to prove it. So sometimes that can lead to variation and understanding what's true or false about this. But for the most part, NASPGHAN is the pediatric GI group. They, in 2008, came out with a consensus statement about what they thought was more consistent. So 5 attacks over any interval, or 3 and 6 months. And the Rome said this is a little different. Maybe they'll 2 attacks in 6 months. And then they said you have to have at least 4 episodes of vomiting in an hour to be CVS, whereas Rome 4 said not so necessary. So you can see how just 2 different groups making 2 different claims about what this is. You can see in general, vomiting a lot, not vomiting for a period of time, and then vomiting again. The NASPGHAN criteria, 1 hour and 1 hour to 10 hours. I'm sorry, that should be 10 days. And then it's stereotyped, and often these people will wake up in the middle of the night. So it's not common for people just to get up in the middle of the night and go vomit. And so if they get up in the middle of the night and then they live in the bathroom for several hours because they just can't go to bed, that's intriguing. You need to start thinking about CVS. And then at the end, when they're finished, they're just wiped out. They sleep for a little bit. They don't want to eat, maybe even for a day or two not eating, and then they're like back to baseline. And then usually you can't find any other cause that would suggest it. So just recently, a paper came out that tried to get at this rather than just with consensus, with some evidence. And so they took over 100 people, and then they diagnosed they took people with CVS and then vomiting people without, and tracked them over time to try to compare characteristics between it, see if we can get some kind of handle on this more than just, this is what we observe. And unfortunately, think about doing the study. You have to make the diagnosis of CVS to begin with. So there's kind of some bias, even already injected into the study. Does that make sense? Okay. So they came up with some guidelines. It's a little bit different from what I just said. So 4 to 10 episodes in a year. So maybe about 1 a month, roughly. And then, but it could be as much as every week, but typically a little bit less than that. Same kind of thing, stereotypical vomiting. And they said 2 hours to 7 days. So a little bit longer duration. And they compared the two groups, and the non-CVS group only vomited on average 3 hours compared to a much longer for those with CVS. 7 days apart at least. And they said just multiple episodes rather than it had to be 4 an hour. So this is the best we have lately. And then there's all these other symptoms that might be associated with it. So you get the sense of what it is. And so you got a patient coming into the clinic and you're thinking, okay, I got one. What do I do now? And if they don't have any alarm symptoms, so they're not, they don't like resemble another disorder that makes you worried, then you can start to think about CVS and start to say, maybe this is what it is. And so, however, to evaluate patients, you could think about doing all kinds of tests, MRI of the brain, laboratory testing, looking for metabolic disorders, a scope, upper GI, and when you do all those kinds of things, you might spend a lot of money but not make a diagnosis. So if there are no alarm symptoms, but you got a good history, you at least want to do an upper GI to rule out malrotation. In your office, if they're older, you might get a urine HCG and a drug screen because you want to make sure you don't have CHS. And then maybe do some chemistries. It would be good to have a discussion about what are you going to do if you're going to come to the ER if you're in the middle of one of these. This is hard because by the time sometimes they get to the ER, their symptoms are gone sometimes. So they come in there and then they wait a long time and then sort of the window is passed to evaluate them. But it'd be good to check some electrolytes to assess their acidosis in case this might be metabolic. You might have other labs that you're going to look at, a lipase at that time to make sure it's not pancreatitis. But if they don't have any alarm symptoms and you're confident in the diagnosis, you might start prophylactic therapy or to prevent these for about 6 months. And if that doesn't seem to work, then you need to start doubting your diagnosis. Or maybe your dose is wrong for the prophylaxis, or maybe there's continued stress, because stress and anxiety tend to be a driver for this. So like family with a divorce or bullying at school, that stress might not be going away, and that might continue to trigger one of these events. So what are the alarm? When do I worry about something else besides cyclic vomiting? The one thing would be unilateral pain. So the pain typically in CVS is right in the center. And so if you have lateralized pain, then you want to think about Diedel's crisis, which is always fun to bring up to sound smart. So I've been doing this job for 20 years, and I've had 2. And so it's not common. Our Virginia's Business Insider's top doc diagnosed one just a few weeks ago. So we've been associated with 3. So it's good to think about, though. Metabolic features. So if this child is like a toddler and they tend to have this when they're fasting, and perhaps you're seeing other changes that make you worried that this is a metabolic disorder, then you might want to check some of the labs, particularly right before they come in to get all their fluids. So like when they first hit the door at the ER. So it might be nice to say, okay, when you come to the ER, we're going to do an ultrasound, we're going to do these labs, we're going to check maybe a KUB, and just to make sure you're not dealing with something at that time. Why an ultrasound? Because if you're going to pick up Dietl's crisis, it's from fluid loading, and what happens is the kidney gets swollen, it kind of lops over the obstruction, or it's trying to get under pressure, and that's what leads to the vomiting until it decompresses, and then you go back to being normal. If you have some bleeding, you could have a Mallory-Weiss tear just from the violence of the vomiting, but it could be something else, and so you might consider additional testing. And then it's important to always be thinking about CNS possibilities. When you're doing your first physical, maybe look at the eye fields, maybe do a decent neuro exam. If there's some gait disturbance, or it's only happening when they lie down, like it's positional, if they you see other changes perhaps of intracranial hypertension, then you might want to start thinking about a CNS cause. So trust but verify. Think about, always doubt your diagnosis, but don't doubt it so much that you don't do anything for the person. So when you think about CVS, there are 4 phases of it. There's this period where they're fine. They're just walking around, they're not having any symptoms. And then they get sick, and they have like a 30 to 90 minute prodrome, a period of time where you get maybe some warning signs. Sometimes it'll be like drooling, or they'll start to heavy drink to kind of decrease the nausea, or they'll just say, my tummy hurts, and then they go to bed and they wake up at 2 and then they start to have symptoms. That's a prodromal time. This might be a good time for us to intervene. And then by the time they're vomiting, it's too late. We just sort of can support them. We want to do rescue therapy, and then they get better, and so forth. So that's the phase. So the prodrome, like I was saying, might have some of these symptoms here. So what do we do in between? So lifestyle changes make a big difference, just like with migraines. So making sure they're staying hydrated, don't fast. A time that I've heard a lot with CVS is they're spending the night over someone's house, and they're really excited about that, and so they're staying up late, or it's on their way back from a vacation, and then they're tired, they're fatigued, they're worn out, and then bam, that's the night they're going to get hit. So a lot of times families, almost 3/4 of the time, they can identify a trigger. They can think about something that's happening that can tell, oh, this is when it's going to start. I had one child who every Sunday night, he would do it, and that's when the parents switched custody. And so it was just really traumatic to that person. And so they were able to say, okay, well, this is probably what's causing it. Or every time they get exhausted, or they're stressed, or they eat certain things. So in this period of time, there are a lot of children, stress and anxiety is a big part of this. And so consider managing that. Now, this little star here means that just yesterday, came in my mailbox. This is the new guidelines for CVS came out yesterday. And so I had to quickly go through that. And the last was 2008, and this was 2025. It really didn't add much, but emphasized different things. But this was one thing they did say. So percutaneous electronic nerve field stimulation is kind of a buzz thing in our world. So we don't do it here. It's called IV stem. There are little electrodes that you can put in the back of the head. Insurance doesn't cover it. And so the family has to pay for it out of pocket, and it sends these impulses into the nerve fields back, and it's supposed to help IBS. Very low recommendations from the committee that they have enough data. It's just like, hey, it might help. So a capsation is like an aggravating cream or an ointment that triggers certain receptors, and is useful perhaps in cannabinoid hyperemesis syndrome and sometimes in migraines. And so also with low quality evidence, they said maybe we could try that. But no, it's not really reached prime time. Yes, sir.
Is there a specific SSRI that is preferred? Like any more evidence for like Zoloft versus some of those?
No, sir. Remember I mentioned that if you don't have alarm symptoms, you could do prophylaxis. If you do have alarm symptoms, then you're going to be working up something else. But even if after you've worked it up and you're confident in your diagnosis, and it looks like their symptoms are frequent. So like if you have a vomiting event every 3 months, Then you're going to do 90 days of treatment to prevent one vomiting event. Not focus on that patient just on abortive therapy as opposed to prophylactic. So, but if you are going to do it, these are some options. The cycloheptadine is an antihistamine that creates fundic relaxation of the stomach, which helps with nausea and also helps you want to eat. So we use it a lot for people who don't eat well when they're young. This seems to be a better agent to use for younger kids, but there was a study that looked at cycloheptadine and compared it to amitriptyline and actually found no difference in improvement, and their age range was 3 to 15. So probably you could still use cycloheptadine in older kids, but in general, I just kind of use 10 years old and under. I'm definitely going to go with cycloheptadine. And so they can also be sedated by this, and some kids have a paradoxical reaction and get agitated. So if you have a young child, or if you have an older person who's not responding to their first line, you might go with propranolol. And then you want to just make sure that you're keeping track of their heart rate, and here's some doses. Tried and true medication that's been very helpful is tricyclic antidepressant, either Elovil or Pamelor. And so I don't use that one very much just because of experience, but and I usually use this in teenagers. It does come in, you have to get it compounded in a liquid, so that has a role to play also. So you want to make sure you check your QT interval before and perhaps during its use. And then when you're done using it, like they haven't had symptoms in 6 to 12 months, then you want to taper it when you come off. So aprepitant is it's a neurokinin 1, and so it's blocking the substance P receptor, which is a trigger for vomiting. And it's highly effective and has become actually, this was in the new consensus guidelines. This is a go-to agent, and you take this twice a week, and here's some dose ranges. This is used for, often used as a pre-med for people who are getting their chemo. Topamax has actually was used in the consensus in the past, is kind of falling out of favor and only being used if you have refractory CVS. Additionally, we talked about it being a mitochondrial disorder, then you can also think about supplementing with these agents here that are often used in patients who have mitochondrial disorders, and I've listed you some doses there. The part of the new consensus guidelines is borrowing from migraines is that magnesium and vitamin D may be helpful, but there's no proof. There's not good proof that it helps. And then if you think you have period or menses-related CVS symptoms, you might think about a low-dose estrogen or even Depo. Going back to our 4 phases, we've talked about prophylactic therapy. What about the prodrome? What can we do in this phase that might intervene? And so looking at a system of retrospective chart review, case-based analysis over 529 studies, only 6 came up with actual quantitative measurement of therapies. The rest of them were just descriptive. So that shows you the dearth of data that's available for this. So coming out from this is answering the question, what can we give to people who are just coming in, or they're when they're sick, when they are at home, they're starting to have symptoms and they think, oh, okay, this is coming on. So Zofran has the highest numbers studied, and about almost 2/3 of them had a 50% decrease in vomiting. Again, it's going to work best if you can try to catch it on the prodrome in the early part. Imitrex or sumatriptan can be used best done intranasally, had a higher numbers, and then here you see aprepitant had highest that decreased the episodes of vomiting. Sedating these patients is not, there's no low quality evidence showing that helps, but just experientially does make a difference. So old school people, when I was in fellowship, I used to moonlight in the ER. These people would come in a lot. We would just put an IV in, start giving them some Ativan, throw them in a dark room, and then hydrate them, let them go to sleep, and they'd wake up and walk out the door. They were fine. So sleep does seem to interrupt the process. So in the vomiting phase, all you can really do is support with fluids and then maybe consider sedation. And then fosaprepitant actually can be given, that's the IV form of aprepitant, can be given in a one-time dose, and that actually might interrupt the cycle. Okay? So now let's switch gears Remember, the difference between CVS and CHS was that there was history of cannabis use, and that when you came off cannabis, that there was cessation. So there's a difference. So the first report of this came out in 2004. And so it was in Australia. And I wanted to talk about this because it kind of just talking about this shows what these patients are like and what we're dealing with. So due to public policy in Australia this time, marijuana was starting to become much more socially acceptable and used. And so some doctors started to notice an increase in people who had what they would have called psychogenic vomiting. And so I think this is so cool when someone recognizes something and they start to pick up a new disorder. So they found 20 patients to study that were doing this. These are people who were cannabis users who were having recurrent vomiting. And so they said, let's get you involved. Well, 5 said, no way, I'm not getting involved. So 5 left. 5 had other pictures, like other drugs that they were using, or they had maybe another diagnosis. So 10 agreed to be studied. And this is a very busy slide, but just to kind of show you a couple of things. Here we go. So first off, the age of onset of use is usually high teens in these people. And you can see here how many years. So 3 years, 3 years, 6 years of use, 17 years, 5 years of use. So long-term use. Then several people stopped it, and they were well for a period of time. Actually, 7 stopped it, and they got better. 3 said, I'm not stopping, and they continued to have symptoms. And that's very emblematic of what this disorder is like. If you don't stop, you're going to continue to have symptoms. 3 of those of 7 that stopped and felt well went back and immediately started to have symptoms, almost within the week. And that's also very much a clue as to how this behaves. And so these are some of those important observations that came from this. So near daily use, cessation led resolution of symptoms for up to 2 years. Interestingly, this early article is one of the few that actually had long-term follow-up of patients. And so it really does show that cessation makes a big difference over the long haul. Resumption of use led to symptoms, and they also observed that hot water baths seemed to offer relief. In fact, sometimes to the point of scalding themselves. And they found that when the water cooled off, the vomiting began again. Very interesting. So, and then they also saw that there was this prodrome. Now, this prodrome is not 30 to 90 minutes. We're talking about could be years of just feeling nauseated, some morning vomiting on occasion. And I think that's a difficult population because they're not having the full-blown cyclical vomiting event. They're not quite so violent, but they're having these recurrent nausea. And so what's not known is, could we intervene? Is this something that we could do something about? So some questions come up. So what is the prevalence of this disorder? Why does it take so long to get symptoms? Are there any kind of marker that we can have to make the diagnosis, or is it just clinical like CVS? And what is the mechanism? Isn't THC an antiemetic? So why is it causing vomiting? And so why is it associated with it? And so how long after cessation does it take for someone to get better? And then why were we not seeing this problem back when I was growing up, when a lot of people smoked pot? So we're going to talk about some of those things. And so the prevalence is difficult to ascertain. So because of the difficulties in definitions, what if you said that everybody that has hot water baths is how you differentiate? Well, that's actually not differentiating anymore. There's actually a significant portion of people who have cyclic vomiting that also do that. And then what about this cannabis use? Well, a lot of people with cyclic vomiting use cannabis to make themselves feel better. So there's some difficulties with understanding what's the prevalence. One estimate is that it's 0.1%. To also kind of figure this out, an ER in New York took patients over a short period of time, so just a few months one summer in 2015, and they asked them to get involved, and they found 155 people who chronically smoked marijuana but were asymptomatic at the time. This is 20 days or more per month of having marijuana. And they found that maybe a third of them had symptoms of CHS in the past, but they used hot water baths as their definition. But that's the best we have, is maybe a third of people who have smoked marijuana are going to come up with this, perhaps. And so why are we seeing more now? So is it because of increased use? Is it because more people are using marijuana now? And so In 1937, marijuana was taken off the U.S. Pharmacopoeia with the Marijuana Tax Act. But then in the 60s and 70s, use really increased. It was illegal, but it has a symbol of rebellion and freedom, and with the hippie generation. But then in the 90s, it started to become more of a national decriminalization process. And you know this just from the news, that almost every state now has some form of decriminalization or legalization. So these ones that are sort of medium blue have it for both medicinal and recreational use. The dark blue are those who have it for mostly medicinal. And then these 3 states it's still illegal. So it's sort of swept the nation, increased availability of this and freedom. And this is another slide showing how the use of marijuana has taken off. So this is sales of marijuana for medical use and recreational use. This is all use, actually. This is taken from the state of Colorado as a sort of a microcosm of the whole. And then the perception of marijuana has also changed over time. So people now, particularly young people, don't think that it's bad for you. And so you can see that, that as people perceived less risk with marijuana, that the use of it increased in time. This is an interesting contrast to cigarette use, which has really fallen off while the use of marijuana has started to increase. So if it was due to increased use, then we should see a rise in cases of patients with CHS associated with that. That is what you see. So in this article from 2015, they compared the time in Colorado before the Attorney General said he would stop prosecuting cases, 2009, and then 2 years later. So you can see the licenses to use marijuana or to dispense it went up from 5,000 to multifold higher, so 118,000. And so in that time frame, they saw that in 2009, they had 41 cases of people coming with cyclic vomiting, and in 2009, and then 87 out of 125,000 in 2011. So that's a prevalence ratio increase 2 times. But when you think about those who are using marijuana, so this is all cases of CVS not necessarily associated with marijuana here, but if you ask them, were you using marijuana and you had cyclic vomiting, it was almost 4-fold increase in that time frame. You can also see that in this slide. This is ER visits in teenagers in 2005 as compared to 2010 with marijuana-related emergency visits. So these are not strong data, but it is showing that increased use may result in increased frequency of symptoms. But wait a minute. So here is the use of marijuana over time. So this is late 70s, and this is now. So yes, it's going up in time, but look at it back here, back in the 70s. And this is 10 years after the heyday when marijuana was even much highly used. And so why were we seeing CHS back then? If it was just from increased rise in use, why weren't we seeing it? So something else is going on. And so over time, the potency of the marijuana has increased. So this is a 10-year look at the changes in potency, and this is delta 9 THC percentage. So back in the 90s, it was around 4%. And then now 12%, and it's probably much higher than that now, because, and this is showing the same information in graphical form. So you can see the 4% here and then going up to about 12. But, and it's not just people using it for medicinal purposes. So CBD or cannabidiol is often the medicalized part, and it doesn't cause the psychoactive properties. But the concentration seems to be heavier in THC compared to that over that same time interval. So I just looked at here in Rona. There are actually 6 dispensaries here in Rona, and that I could find. Maybe there's more. And I just want to show you. Look at that, 86% in that, 86% THC in that vape. So cannabis in the legal market, dispensaries on average has THC even higher, 20%. People want these higher percentage amounts to get their money's worth. I just threw this gummy worm thing in here because it bothered me. If you just laid that on your coffee table and your toddler came in and said, "Oh, that looks like candy." We know, I didn't want to spend too much time on this, but there are some adverse effects of marijuana beyond just CHS. And so addiction is certainly a big one. And it looks like addiction overall is about 9%, but if you started as a teenager, then your chance is higher that you'll be chronically addicted. And then if you're using it every day, it's on a regular basis, 25 to 50% of the time. So, but aren't there some good uses, and there's some medical uses, definitely. So it helps with glaucoma. It helps with people who are having trouble with weight gain, both cancer patients and those with wasting with HIV. There's some evidence that CBD more than THC can help inflammatory conditions, although it hasn't really reached prime time. And this has been a statement that people have made for about 10 to 15 years. It definitely seems to be the only thing that helps some people with seizures. And it is an anti-nausea or an antiemetic. So why? Why is this happening? So kind of don't glaze over. We're going to talk about a little bit about the endocannabinoid system for a minute. And just so you can understand the vocabulary. And I want to direct your attention, this is presynaptic and postsynaptic. I should have put in my disclosures that I'm not a neurologist. So if I say something neurologically incorrect, then please correct me. So this is presynaptic. So these are CB1 receptors. This is the cannabinoid receptors. This is where THC binds, predominantly CB1. So they bind here, but they also bind here at the TRPV1, which we'll talk about in a second. We have exogenous stimulation of these receptors, and then we also have our endogenous. So this is something that's happening while we're sitting here. We're stimulating us to be less nauseated when this is stimulated. It also helps control gut secretion, gut motility, also affects inflammation. So the endocannabinoid system is important to us, and that's where THC stimulates and can be beneficial to a degree. And so it's an potent antiemetic. So this is the only thing you'll remember from the talk is that rodents cannot vomit. So I found that out when I was talking about this. So that's all you'll remember. When I talked about gallbladder disease, the only thing you remembered was that there's a Phrygian cat that looked like the Smurfs. So this one is what you'll remember. But I thought that was interesting. But they do gag, and you can give them a chemical that makes them gag, or you can work with ferrets and shrews. I think that would be fun research. Just see what happens. So, but then you can actually give you can give them THC. Give the medicine that makes them vomit, and nothing happens. So they don't vomit, they don't gag. However, if you block the CB1 receptor, they'll gag again. So CB1 receptor, just shows that THC is a potent antiemetic. In humans, it also, remember, serotonin is a stimulus for vomiting, so it inhibits its release and also inhibits the receptors. So it's an important potent, and you know this based on low-dose medicines that are on the market. So nabilone, which I've not used, or dronabinol, which is sometimes used by chemo doctors for people who are having trouble eating and having nausea with chemo, are very low-dose THC analogs that do work. However, chronic and high-dose stimulus of those receptors may serve to be pro-emetic because they downregulate those receptors, they internalize, they go away. And actually, when that change in the amount of available receptors almost becomes like a pro-emetic stimulus. So the more that you're giving it, the less receptors, this is still conjecture, then you have increased sensitivity. In fact, some patients will say, once they start to develop CHS, that even the smell of marijuana will trigger it. And that might be just a learned response. So this transient receptor potential phenyloid 1 also may play a role, not a role, I thought I'd call it a typos. And so that's over here to the side. And I'll just bring this up for one thing, is that it's also a capsaicin receptor. And so that's why people have tried to use capsaicin. This is also important in dealing with pain coming from the gut. And so if you're blocking that, or you have something that's overstimulating that, that's why these people are in intense pain. 85% with intense pain with this. And so it depletes substance P, so it helps with nausea, but the overstimulation does the opposite. And then also, It's involved with vasodilation of the splanchnic bed, and then you get cutaneous vasoconstriction. So that might be why the heat on the extremities helps to reverse that and decrease some of the symptoms. And it might be working actually out at that receptor. Okay, so another thing to know is that THC is lipophilic, so it gets stored in our fat and then over time will be released. So if I stop using it, it's going to continue to come out. So it could be that with time, it's going to take a long time before it's really fully out of the system. If you get stressed, that actually might lead to release of it because it's going to start turning on lipolysis and release the more THC out. So it could be that might be a trigger for one of these events. Interestingly, 205 patients were tested for those who were 205 marijuana users, for those who had CHS and those who did not, and actually found some mutations in some of these receptors. So then there are phases of CHS. There's this prodrome phase I mentioned where it could go on for years, where they're having some morning nausea, maybe some anxiety, maybe some sweating. Very difficult to diagnose. If you do a UDS or a urine drug screen, what do you do with that patient? That's a question I was hoping to answer in the literature and I could not find. I think that's the hard thing because I'll talk to you about this in a minute. Patients don't believe you when you tell them that this is the cause. And then they have this hyperemetic phase, and this is intense, it's relentless, and it's worse in the morning, and they cannot feel well. A lot of these people can't function, they can't eat, and many times it drives them to the ED. And so until they can feel better, they get online, they learn about hot water bathing, or what's going to help them to feel better, and then they might start smoking more, thinking they're withdrawing. And so the recovery comes from abstinence. Almost 100% will get better with abstinence, but it might take 3 cycles or maybe even as long as 6 months to see the effect. Okay, we talked about the Rome criteria, but and then how it's the use of this. We talked about hot water bathing and the pain. So, and then these characteristics. So we know about these things, but you can see how important cessation of use is to making the diagnosis. Hot bathing is frequent, male predominance, and then abdominal pain. Some other things that you might see is that are a part of this is that symptoms come back with use when you restart it. Frequency of use. So remember from that first paper that it was years of use that led to the before they had symptoms, and then we're talking about using it almost daily. This is more than daily frequency. This is daily use, weekly use even can lead to symptoms. So what else can look like this? So if you're having, remember this is probably has a lot more intense pain than CVS, but you can have pain with both. So certainly cyclic vomiting is real common. But you have to think about biliary disorders, think about pancreatitis, SMA syndrome with the chronic vomiting, or small bowel obstruction. So when you're seeing these people, what should you do? You might get some labs to check for, particularly when they're coming to the hospital. You want to check to make sure they're not pregnant, do a urinalysis, lipase, and check them for electrolyte abnormalities. Interestingly, get a baseline QT because a lot of the therapies, a lot of the antiemetics will elongate your QT. And then you also want to track that in time. So make this part of your order set when you see somebody coming into the EDs. Get an EKG when they roll in. You might want to check an image to make sure they're not obstructed. You might ultrasound their gallbladder, CT if they are having suggestive symptoms. So I'm bringing back the where we can block this, and so antiemetics seem not to help in this. So whereas Zofran seemed to help in CVS, these tend not to be helpful. What has been shown to be helpful is Haldol, and so it seems to be of higher quality. Of course, the research on this is low, but in one study looking at comparing Zofran and 2 doses of haloperidol showed that both doses improved using a visual analog scale somewhat significantly. They had higher treatment success. They had overall less use of antiemetics, and they shortened their stay in the hospital. Higher dose Haldol led to extrapyramidal symptoms. And then Aprepitant, again, can be used, and this is substance P coming in. This is what aprepitant, where that blocks. So you don't want to use, even though they're in pain, you don't want to use opioids. You might use some Ativan to help calm them down. Capsaicin has been applied to the abdomen. Remember, that binds to the TRPV1 receptor, and it might reverse the effect. Just looking at a small series to underscore this, 6 adolescents with CHS presented to the ED. 4 of them got haloperidol plus some Ativan. All of them got better. 1 of them got haloperidol and some capsaicin rubbed on their belly, and they had complete improvement. Capsaicin alone, only a small amount. This is a small study. You can't necessarily say that's representative of the whole, but it does seem like it's a different approach than giving Zofran alone. And then what do you do after they've kind of calmed down? You're getting ready your discharge planning. After they've left, getting ready to leave to go to the hospital. Interestingly, using tricyclics might be helpful, just like with CVS. Those studies are using significantly higher doses. We might start at 10, maybe work to as high as 50. And once they've gone 6 to 12 months, you might taper that off. And abstinence may help, but it might take weeks before you start to see it actually improve. Remember, those receptors take a time to regenerate. Plus, it was in the fat, so it's going to be being released over time. And so having them meet with somebody to help them deal with the withdrawal of that might be helpful. So I mentioned that patients they don't trust you when you tell them this, particularly if they come in and you don't do anything else. So if they come in and you haven't done any other tests, and you know in your heart what it is, so they're vomiting like this, and you do a urine drug screening that's positive, and then you just nailed them. And so you know what it is, but they're like, you don't know what you're talking about. You didn't test this. I don't believe you. In fact, this was a paper that came out, and so this was just taking interviews with people who had been told that they had CHS and what they thought about it. Mm-hmm. So it's very difficult to get people to do abstinence, particularly when they feel better temporarily when they use it. So I actually will tell them, you might feel good, and you might think this is the only way out. This is your only way out of this, because they'll start to get desperate in time, and some will start to believe you. But recidivism is high, and you have to tell them that if they start up again, they're going to start to see their symptoms come back. It takes a while and to get them to believe. So we have like 5 minutes to talk about differentiating these two, because these are very similar presentations, with the only difference being one seems to be higher use of cannabis. But remember, people with CVS use cannabis also to help them with their symptoms. Can you just go with a positive drug screen? So this is an adult study showing the use of marijuana in people who have CVS. This is 18 to 35-year-olds, significant number of people using it with time. And so probably a better paper looking at this is looking at 141 patients or 140 patients, and they looked at people who had cyclic vomiting to determine how much THC use, and they found that about 40% were using and 21% were heavy users. So all these over here are users. This is your heavy user group, and they actually had a substantial number abstained for a month, and only 1 improved. So that makes it difficult to use cannabis alone as a differentiating tool, perhaps. But perhaps a longer period was needed of an abstinence to differentiate that. So water bathing was seen in 92% of those with CHS, but also in about half of those with CVS. There's actually been reports of water bathing in little kids who have CVS, who've never had THC. So that alone may not be helpful for us. And so some argue that CHS is actually a subset of CVS. So a paper came out in the Journal of Pediatrics to try to differentiate these two in the pediatric population. And so they looked at 200 patients, this is retrospective, at 2 hospitals in Atlanta, looked at various variables to see what there were differences. And they looked at all kinds of stuff. The only thing that really came out was age. So higher age, it's going to be more associated with CHS, and CVS in less age. And this is sort of logical. A 5-year-old, you're not going to be doing a urine drug screen on. So where that line is hard to know, maybe 12, but it's hard to know. And then a positive UDS, this is also just makes sense. So those who have CHS 86% CVS. So maybe those are useful things. So, and blood pressure seem to be higher in both, but higher in CHS. So maybe we just know it when we see it. So rather than use a criteria. In fact, I had a patient yesterday that I scoped and started to get some history afterwards, scoped her for vomiting. And the family said, we just don't know what's going on. She has these pain events every 4 weeks. And it wakes her up at 3 a.m. And she does all this for hours. And then we have to go to the ER. And then I had, so we talked about this for a while. And then I asked them if she was using cannabis. They said, oh, she's been with this boyfriend. And I think he's been bringing her stuff. And then the more we talked about it, I think that we were onto it. So we did a urine drug screen, and I think, so it's not confirmed, but it is kind of like you can know it when you see it for the most part. So we've talked about how these two are similar disorders. Maybe age, prolonged cannabis use, and improvement with abstinence and time may be helpful. Now, if it takes 6 months perhaps of abstinence before you truly can know, it's going to be kind of hard to make that differentiation and convince your patient. So you have to remember that. But abstinence is going to make it better. So you might ask them, why don't you try this for a while? We talked about treatment, including fluids, antiemetics, that migraine abortive therapy might work with CVS, and then maybe Haldol and capsaicin for those who have CHS. We talked about long-term treatment when time with tricyclics, cycloheptadine, propranolol, and aprepitant, abstinence in CHS, and how the diagnosis and therapy may help prevent many nights in the ED and significant cost. We're supposed to have some questions at the end. And so a 5-year-old has a history of waking up, having vomiting in the middle of the night, lasting hours and resolving in several hours, and then seems to recur every 4 weeks. There are no alarm symptoms. So which one of these do you do? What's your next step? Do you get stool studies to get a calprotectin and a lactoferrin to look for inflammation? And then you start empirical and acid blockade and as needed on Dansitron. Or do you get an ultrasound of the kidneys and urinalysis and a drug screen and as needed on Dansitron? Or you send them to us for a scope, start acid blockade and as needed on Dansitron. Or you get some labs, you get pyruvate lactate. Remember, this is younger child, so pyruvate lactate, urine, organic acids, plasma amino acids, and as needed on Dansitron. Or you get an upper GI, electrolytes, lipase during an episode if possible, and consider prophylactic therapy with cycloheptadine or propranolol, and as needed on Dansitron. Which would you choose? E is correct. Good. And then which of these are easy, which of these therapies, list more than one if you think, would be helpful in CHS? What?
Fluids and haloperidol.
Fluids, haloperidol. What else? Anything else? Maybe tricyclics on their way out. Zofran and Reglan, remember, you can try, but they tend to not be effective, and that might be a clue what you're up against. And then run criteria for CVS includes all but which of the following? There's one of these is not right. So stereotypical episodes, yes. 3 episodes in the last year, yes. 2 in 6 months, yes. Started, actually it should be, started at least 6 months ago. And then they have episodes at night or absence of vomiting between spells. So actually they don't specify that they're episodes at night. So that's not necessarily stereotypical. That is seen a lot if people have CVS, but it's not always, it's not a must. So any questions? Nothing. Okay. All right, nothing online.
With regards to CVS, has there ever been a connection or relationship found with any autoimmune conditions, especially celiac disease?
No, it has not been seen. Autonomic disorders, yes, maybe, but not autoimmune.
Is there any studies looking at like the family history of migraines and helping to differentiate between CVS and CHS?
No, actually, there's a high percentage in both. And actually, if you look at when they did that study, I know I threw a lot at you, but there was a study where they tried to look at diagnostic criteria for CVS, and they tried to see, they had the non-CVS and CVS, and they were trying to compare, trying to find things. Actually, family history of migraines was not differentiating, even with CVS. Yes, sir.
The SSRIs you mentioned, I know in autonomic dysfunction, we use the ones that have SNRI profiles as well that are helpful, like viloxazine and fluoxetine. Drake was asking earlier which ones would be more helpful. I mean, those are the ones that we typically use as a fourth line for our dysautonomia patient. I don't know which you don't know which ones would be more helpful.
I think that with the focus, the stress and anxiety being more than autonomic control being the goal. So I think that differentiating one particular type, I would say no.
Thank you.